Tom Wadsworth here, and I'll just do a quick word on my background. For the last 18 years, I've been with the Cleveland Clinic, reporting to the number 2 guy at the Cleveland Clinic. Basically, in a nutshell, was involved in performance improvement across the hospitals and across the clinics side of the house as well, looking at things that would address financial performance improvement, operational performance improvement, patient experience, and clinical performance improvement. You see in my title here, there is something related to CareFX, and this is a Cleveland Clinic presentation. But as a not-for-profit, we also want to disclose these relationships, and some of them are very recent. Quick background, in 2007, 2008, we started making national presentations of our dashboards. And that was evolved from about 15 years worth of work. These have been evolving since about 1993. And based upon that work, from the national presentations and feedback we got from folks saying they would like some help, the Cleveland Clinic decided in 2009 to spin off a company called Intellis EPM. Throughout 2009, as we were doing the spin-off, we began to realize that we could use some help, and through collaboration with a well-established software organization. And in May, just very recently, we announced a collaboration with CareFX. CareFX has exclusive licensing rights to market and develop our products in collaboration with Cleveland Clinic, and we're off to a great start with CareFX. Cleveland Clinic, for those of you who don't know, is a main campus, is a 1,400-bed academic medical center with 2,000 employed physicians and scientists. We have now actually 10 community hospitals in our system, and as well as a hospital in Florida and some activity going on in the Middle East and Las Vegas. Here up in Cleveland, we have about 100,000 discharges, 4 million outpatient visits, and over a $5 billion, almost a $6 billion net revenue organization with the Research Institute and Medical School. So I want to take 4 slides and just go through kind of the history of how we got to where we are right now. And these slides are instructive around the governance side of succeeding with business intelligence and enterprise performance management, as they are around the technology and how the technology evolved. We really started in 1993, and the question in 1993 was, how do you know whether you're doing well or not? And the answer at that time was, well, on the 15th of the month, I get an income statement for the previous month, and if that's black, I did well. If it's red, I didn't do well. And that was about all we knew. So we decided that wouldn't it be great if we could manage all of the component parts that would make sure we would have a good financial outcome at least the 15th of the next month. We identified about 20 metrics we wanted to track. And then the next question was, does that metric exist anywhere? And more often than not, the metrics existed on a foot-high mainframe audit report someplace in the computer system. You know, an example of a metric might be, how long did it take us to answer the phone when a patient was calling for an appointment? And we discovered some things that we didn't know. One of the things, for example, we discovered was if you're calling for a cardiology appointment, we waited 2.5 minutes, which is 25 rings, before we even answered the phone on average. So we quickly went to producing those metrics on a monthly basis with these graphics that you see on this slide, and establishing targets. So, for example, the target for answering the phone was 25 seconds. And over a period of several months, everybody's performance improved down close to or near 25 seconds. On the right-hand side, then in 1995, we took those monthly trended reports, we put them on a wheel so you can see multiple metrics on one page. So the way the wheel works is the perimeter is in green is the target. If you were beyond that target, outside of that wheel, that was better than targeted performance. If you were inside, that was called a ding in the wheel. That was less than expected performance. You know, we got this far, and we had some performance improvement, but really the next step and sea change happened in 1998. So in 1998, the Cleveland Clinic lost about $100 million from operations. It was the first year we had lost money in the 80-year history of the Cleveland Clinic. So at that time, the CEO, Dr. Loop, decided that we're running the organization based on bureaucratic or political foundations, and now we were going to convert and shift and run the organization based on a rational model based upon the data. And he used these wheels to drive that performance improvement. So there were monthly meetings, and this picture on the left is an example of one of those monthly meetings where the chairman would come in and they would project their wheel and they would talk about where they were doing well and where they were not doing well. There was a little bit of competitive juices flowing at these meetings, but there was also significant organizational learning going on because, any area that begins to improve their process and had a innovative idea to improve performance, everybody got to hear about it and learn from it. In 2002, we converted those wheels to the web to facilitate distribution of that data. For any of you who have been doing this, you know that distributing things like this to, in our case, 150 departments is a extensive project. So at that time, the chairman were looking backwards every month of these meetings at a month's worth of performance and having to react to this data. So the next sea change was in 2004. And in 2004, one of the chairmen in pediatrics said, well, I'm tired of coming to these meetings on a monthly basis and having to look in the rearview mirror. I would like to manage my performance on a daily basis. In fact, those wheel meetings sometimes were uncomfortable. That wheel format was initially called a performance wheel, then it became known as a wheel of fortune, and then after a couple of years it became known as the wheel of death, because if you came to those meetings not knowing what your performance was, in that particular point in time it was an uncomfortable meeting. So anyway, the upper left shows an example of one of the dashboard performances that we had related to working year denials. And we had a target of, and without getting into the detail of the metric, the goal was to have at least only 5% of your denials left in your denial database. And you can see right here in the middle is when we converted this metric to a daily statistic, a daily metric that would be available to the departments as opposed to a monthly. And you see a dramatic improvement in performance. The lower those bars, the better, and it was sustainable. So we discovered that daily data provided in a easily interpretable format drove significant performance improvement really across the board. So at that point in time, we converted all of our dashboards where appropriate to a daily metric as opposed to a monthly metric. That created another problem, though, because now we're sending daily data out to 150 departments. We needed to look in 2005 for some technology that would facilitate distribution of that data. And that's when we got involved in dashboard tools and data warehousing. And then starting in 2006 and going forward, we have newer iterations of those dashboards, which I'm about to show you next. Just before I do that, at a high level, what's happening is prior to the data warehousing initiatives, we had transaction systems on the left-hand side feeding into different reporting mechanisms. And every department had their own analyst, and every analyst had varying skills in terms of their ability to extract data accurately out of the system. So that resulted in wasted resources and contradictory reports. This probably happens at none of your places, but at the clinic, I was in charge of medical operations, and my counterpart in finance, we would often go to the executive team and report on some of the same metrics, length of stay, census. We never had the same number. And in fact, the goal was to be the first person in to see the CEO and report your numbers, because then that was the truth, and everyone else had to fight against that. We evolved then to a new mechanism where we had the feeder systems going into a data warehouse. And we actually got along very, very well between finance and operations, and we would negotiate through what's going to be the source of truth when we report on a number, like length of stay, for example. So now when we report on length of stay, the numbers we produce are the identical numbers because we've agreed on what the source of truth would be. This data warehouse mechanism also combines and co-locates information, for example, on quality and cost. So we begin to look at interrelationships, for example, between quality and cost. Does high-quality care cost more money or less money, as an example? So for us, remember I told you in 1998 we lost $100 million from operations. We had an immediate turnaround, and the CEO would tell you that the reason for that turnaround was this use of these dashboards, which I'm about to show you, and the cultural accountability that it supported. And then in 2009, we actually had the best year we've ever had as an organization as well. So now I'm going to go into these dashboards, and I'm going to show you a few. The clinic has in production now about 20 dashboards listed on the left, and we're developing about 10. We have another 80 in the pipeline, so it is, or actually on the wish list. So it is the way we run and manage performance here at the clinic. As in TALIS or CareFX, we have and are taking these dashboards one by one and putting them into a commercialized format. That's what these check boxes account for. So dashboards around quality, hospital throughput, and quickly developing documentation coding and utilization management dashboards that help drive performance improvement in those areas. So now I'm going to show you the system demonstration and just quickly go through a broad range of types of dashboards. It really starts at the top with the Institute scorecard and some of the take-home lessons I've put here across the top. And the first take-home lesson really is you want the dashboards to align with the mission of the organization. So the very first dashboard that I'll show you is the executive dashboard, which has the Institute scorecard in it. And the way this works is on a monthly basis, chairmen come through for a very structured discussion around the strategic objectives of the Cleveland Clinic Health System. So, for example, this is a drop-down box. These meetings are done electronically, and this is the exact screen that they use. And let's say the chairman for Heart and Vascular Institute was coming in. So we'd click Heart and Vascular Institute, and that institute's metrics pop up on the screen. And the way this works is the high-level metrics are on the left-hand side. So our metrics are sorted into quality, patient safety, patient experience, access, and financial performance. And secondary metrics are on the right-hand side. So since I've highlighted quality and patient safety, up by quality and patient safety, I have red light, yellow light, or green light. And those are really, it's a medal count of how many metrics have achieved target. If you've achieved target, you're a green light. If you're not close yet, you're a red light. Since I've highlighted quality and patient safety as my row, my detail metrics for quality and patient safety show up on the right-hand side. So I can see that hand hygiene targets to be at 90% compliant. We're actually at 92% compliant. And down below, I can see a trend line for how my performance has improved over time for hand hygiene. As a quick note, I told you that these metrics are collected on a daily basis for the most part. I mean, some of them are weekly and some of them are monthly, but where appropriate, we collect them daily. And 99% of the metrics are collected electronically without any physical person touching that metric. Hand hygiene happens to be one of the very, very few exceptions to that rule. Since hand hygiene and compliance with hand hygiene is observed physically, that data is then entered into the web directly and then into our data warehouse and dashboard. So the CEO would look at this and say, okay, 1 green light on quality and patient safety for hand hygiene, 2 red lights on verbal order sign-off and core measures. What can I do to help you? And then each chairman, the chairman for Heart and Vascular, would say, here are the interventions I'm putting in place to improve my compliance in those other metrics. Then they go into the next category. So say patient experience, which are the selected HCAHPS domains we're monitoring. Incidentally, so this is the highest level dashboard. We've selected just a few key metrics that we're going to track. Below this are cascading many dashboards that cascade underneath this, roll up to the same numbers. All the numbers roll up and they're sourced from the same source system, but different levels of granularity down to the granularity of a frontline manager working something like patient experience. So patient experience, you'll see later on, that goes down to the nursing unit level of detail. So that's how this dashboard works. And again, this is aligning the organization with the vision and establishing a mechanism for accountability to the strategic objectives of the organization. I'm going to show you a few different kinds of dashboards now. First one I'm going to show you is a blood utilization dashboard. And to tell you how we think about these dashboards, blood became a high priority for us because we were the #1 purchaser of blood in the country, which is both a cost issue, but it's also a quality issue. So the take-home message here is transparency and accountability. Transparency is, I think, one of the core values or guiding principles of the dashboards, as you'll see. We'll show you nursing units by name. We'll show you physicians by name. And any chairman can see any other chairman's performance. Within a department, any physician can see any other physician's performance. And that culture has evolved over time. We did start off with blinding. So let's talk about blood utilization. So the goal here is to come up with decision rule, right, not 100% of the time, because then it would have been so, fine-tuned that we would be paralyzed. We came up with a generic rule. And the generic rule for ordering blood was if the hemoglobin is greater than 9, then there was a chance you didn't need to order that blood. If the hemoglobin is less than 7, this is based upon the physicians coming up with an evidence-based practice rule, then you definitely did need to order the blood. Anything in between was a question mark. So we converted those 3 metrics to a red light, a green line, and a yellow line down below and tracked performance in terms of ordering patterns. Now you can see, for example, under Surgery Institute, 35.5% of those orders are for patients with a hemoglobin greater than 9. Now there could be a good clinical reason for that, may not be. I happen to have highlighted orthopedic surgery on this metric. I can click into more detail on orthopedic surgery, and get physician-level detail. And this is the kind of information that's reviewed at monthly meetings with the chairman and the physicians. And you can see some over here, for example, Dr. Howell. At this point in time, 68 of his 78 orders were for patients with hemoglobin greater than 9. So the next slide, the middle graph, shows you a declining trend of blood being ordered per 1,000 patients. Just doing this project by itself, before we tracked any data, we think saved us about $400,000 on blood on an annualized basis. And now that this is being tracked more aggressively, we see that number becoming more effective, using less and less blood. Some of our more recent dashboards are based upon a cube technology, which we have found very, very powerful in terms of providing intuitively understood data. Essentially, we think of the data as a big cube of data, and the first thing we did was we indexed that data to facilitate drilling down and establishing accountability. So, for example, on the right-hand side, we would build the physician structure. So we'd index the data to the physician structure. We'd index the data to the physical structure. So if you have multiple hospitals down to an individual nursing unit, we'll have that indexed. And in this example on the left-hand side, we've indexed product lines. So, for example, at the Cleveland Clinic, with 750 MSDRGs, 62 nursing units, and 2,000 physicians, there's literally 90 million cells in this cube of data. And the question is, within any one of those cells, I may have some performance that I need to evaluate. So the goal in our technology was, by providing hints, and within about 3 mouse clicks, I want to get down to that area that needs to be evaluated. So I'm going to show you a couple dashboards here that use this technology, and we'll give you the idea of how this works. But remember the shape of that cube and how we're indexing and getting into this data. So I'm going to start with quality dashboards. And by the way, the take-home message for this next series of dashboards is you want to orient your dashboards to the specific user. So if it's a CEO, they need one level of data. If it's a chairman, they need another level of data. If it's an individual nursing unit or physician, they may need another level of data, which is specifically oriented to their view of the world. We have mortality dashboards, core measure, patient experience, and physician scorecard. I will show you the scorecard, but I'll skip core measures and patient experience. And let's just start with mortality as an example of how these work. So you remember that cube. One of the dimensions of that cube was the physician structure. Well, that's what's over here on the left-hand side of this particular dashboard. On the right-hand side at the top, we have a trended performance. Then those other two dimensions on that cube were your physical structure, so your hospital structure, and your product line structure based upon MSDRGs. And we'll show you that on this page, there are 4 ways of drilling into this data in an intuitive fashion. I can drill into any one of these rows on the left-hand side. I can drill into any of these icons, or I can drill into any of these bars on the right-hand side. We also said we wanted to provide cues because you can't go into 90 million cells and check every one of them out one by one. So we used green lights, red lights, and exclamation points to do that. So you see at the very, very top, for example, for the whole hospital, for mortality, we're measuring in these columns observed to expected deaths and then excess deaths. So negative 346 excess deaths means 346 fewer people died than were predicted based upon the APR-DRG for the most part, the APR-DRG metric that we're using to drive expected mortality. The first red light you see is for anesthesia, but that only has an N size of 31, so we're not going to go there. Go down farther, you see an exclamation point on heart. So that gives you a cue that heart overall is a green light, it's doing well, but there's something behind there that needs to be reviewed. So we're going to drill into heart, and the next dashboard now shows you on the right-hand side the graphs reflect heart performance. And I can see that cardiology is a green light with negative 47 excess deaths, but cardiothoracic surgery has positive 0.4 excess deaths. So that's why we had that red light on cardiothoracic surgery, and that's why we had an exclamation point on the previous page. I told you that the graphs on the right-hand side are drillable. In this case, it's a system with 3 hospitals. I'll drill into hospital A, and I can see nursing unit, summary unit level detail. I can drill into heart ICU and see the individual performance of each ICU. So within a click of a button, you've gone from a very high level of the organization down to an individual nursing unit. So I'm going to go back up and look at heart in general now and drill into cardiac surgery. So I'm going to drill into this icon, and when you drill into an icon, you get a detailed report. This particular detail report breaks out the data. There's prefabricated reports that break it out in various ways. This happens to be a view looking at MSDRG. So I can see that for cardiothoracic surgery, MSDRG 219 on the left-hand side had 37 cases. I had 8 observed deaths, and I expected 3.83 deaths based upon the statistics. So I have a ratio of 2 observed deaths to every expected death, and excess of 4 deaths in total. So let's say I want to drill into DRG 219. So up above, I'm going to pick by MSDRG, by physician. It's a scrollable report. I'll scroll down to MSDRG 219, and I can see these 2 physicians at the top that are highlighted in red are the ones that had excess deaths. And that would allow me to know, what's happening by physician for that MSDRG. If I wanted to view all my cases for my cardiac surgeons, I can just click on this by physician report, and I can see that Luke Holland, for example, is the only one of the 4 cardiothoracic surgeons that has excess deaths, 5.56 in his case, for this period of time. Now, that could be a function of clinical performance, or it could be a function of documentation how sick those patients are, and potentially underestimating their expected mortality. We include on this one for the clinic 3 columns, one for complications, comorbidities, and secondary diagnosis codes. And if you notice for Luke Holland, he's the lowest in terms of secondary diagnosis codes and comorbidities compared to his peers. So this may be a documentation issue. And we have another set of dashboards we do which drill into, or we're working on, that will drill into documentation performance, which I'm not going to cover in this particular presentation. But drilling into Luke Holland, now everything that's underlined is drillable, so I'll drill into Luke Holland, and here are the 12 cases of his that died. I can see, for example, I would like every patient in risk of mortality column, I would like every one of those to have extreme, because every one of them died. So I see some that are major. I may want to go in and look at a little bit more detail on those particular patients here within a click now. We don't have to go to the medical record system or anything. We have a profile of more detailed data that can be gotten at with a mouse click. And this provides, again, more level of detail. I'm going to move on to one more feature of this dashboard, and all the dashboards actually. Remember that cube shape? Well, we have the ability to, with a push of a button, turn that cube on its end. So this view showed a physician view of the world. I'm going to change this to show a product line view of the world by MSDRG. So I click this radio button, and now my physician structure went to the lower right-hand corner, and my MSDRG structure went up to the left-hand side for primary evaluation. I'm going to click into surgical MSDRGs, and now I'm not going to in this presentation show it to you, but I could drill into specific MSDRGs. But for example, for bone marrow transplant, I see I have a green light, 4.14 fewer negative excess deaths. We do have this linked in with a comparative database, so I can see from a mortality perspective, we rank 21st out of 56 hospitals as it relates to mortality rate within BMT. And then finally, I could click on this location radio button, and let's say it's the CEO meeting with the presidents of the 3 hospitals, CEO of the system meeting with the presidents of the 3 hospitals. We can see the performance for each of those hospitals, and then all the drills. You could drill in the hospital on the left-hand side, or you could drill into services or MSDRGs on the right-hand side. So all the same functionality exists. So hopefully that gives you a flavor of how we've built a very intuitive tool that allows the executive team and the direct reports below the executive team to drill into it to identify quickly performance. I'm going to go on to a new dashboard, which is our physician scorecard. And the purpose of this particular dashboard, we did mortality and patient experience and core measures dashboards. Well, the CMO at the hospital that we built these for initially said, gee, I love those dashboards, but I would love to see on one dashboard all of those side by side. And in his mind, this was the beginning of an OPPE project. We could begin to look at adding on other metrics like readmissions, length of stay, things like that, to turn this into an OPPE product, which is one thing we're working on with them as well right now. But we have our physician hierarchy down the left-hand side, and columns for mortality, patient experience, core measures. Let's just drill into internal medicine, for example. And now I see my departments for internal medicine. Let's say I wanted to drill into pulmonary. So now within 3 mouse clicks, I'm down to individual physicians within the pulmonary department. The graphs on the right reflect the pulmonary department, and I can actually click into a physician. So I'll click into John James, and now the trend graphs on the right reflect John James, and I can actually, since I have a magnifying glass next to him, I can click onto that magnifying glass and pull up detailed reports. So mortality performance by MSDRG, HCAHPS performance for Dr. James, and core measure compliance for Dr. James as well. So again, very, very quick, intuitive drill down based upon red light, green light to a high degree of specificity. Okay, I'm going to change gears again, and I'm going to really just spend the next 15 minutes or so showing you a couple more examples of dashboards because everyone has a little bit different flavor. The take-home message for this next discussion is really to drive performance improvement in the organization. What we have found is that showing variation in performance for peer groups is what drives the fastest performance improvement in the organization. So I'm going to do this through a hospital throughput and capacity dashboard. To give you a bit of a background on the results for us, this slide basically kind of gives you a picture that says Cleveland Clinic, back when we started this, was a 1,000-bed hospital. We had 200 ICU beds that were 100% full, basically 24 hours a day, 7 days a week. Then we had 800 regular nursing floor beds, and we were stuck at a census of about 682 as our baseline. And we didn't think we could fit many more patients than 682 into those beds. Over a period of 3 years with some throughput initiatives, we improved that average census from 682 up to 753. And to give you an example of the financial impact, for every increase in average daily census of 1, we calculated that was worth, very conservatively, about $500,000 net income. So by the end of year 3, we were driving $35 million of net income incremental into the organization through this initiative. Some of the really good organizations in the country, like Advisory Board, they'll publish that if you get beyond 85% average daily census, you can't run an efficient hospital. And we were going to write a paper that said how to run an efficient hospital beyond 90%. We finally settled out at about 92% average daily census across 7 days of the week. So I'm going to just do a highlight of what this dashboard, how this dashboard works. I'm going to just focus on a couple quick metrics to give you a handle of how it works. I'm going to look at discharges by 11 a.m. So the business issue here was, for example, the surgeon rounds at 5 a.m. Actually, we call them stealth rounds here. So they're round at 5 a.m. Maybe the patient's awake or not, but stealth round because they maybe won't talk to the nurse when they're rounding. And then they'll think, okay, this patient can go home today. We'll see how some of the tests run. Go to the surgery all day long. Come back 5, 6 o'clock at night. Discharge the patient, and the patient goes home at 7 o'clock at night. Our average time of discharge when we started this was about 7 o'clock at night. We reduced it over the period of 3 years down to about noon. But anyway, when we clicked on discharges by 11 a.m., the first thing that popped up below that was a little more detail. So by discharge type now, I can tell how my performance is. So, for example, if someone was deceased, 41.6% of them are getting out before 11 a.m. Well, that's not necessarily a great outcome. But if it's a skilled nursing facility at the bottom, only 7.4% of those are getting out by 11 a.m. So that level of detail provides me the ability to focus in on what areas have the biggest need for improvement. Now, on the right-hand side, remember the goal here was, or the take-home message here was, variation in care drives performance change. So, for example, we can see that psychiatry is the most compliant in terms of getting patients discharged by 11 a.m. I can drill, these are drillable, so I can drill into surgery here, for example, and the next thing that pops up is the physicians. And these are sorted, these yellow stars are sorted left to right in terms of end size. Well, notice right in the middle, there's a physician who is almost at the compliance, clearly better than anybody else. So the question is, what's the best practice that physician is doing that's allowing their patients to be getting discharged by 11 a.m.? Same thing goes for nursing units down on the left. So I'll click on surgery, and surgery units pop up. So the question was, what is it about CB4, this unit in the middle? What are they doing to achieve such high compliance with discharges before noon or 11 o'clock? Is there a best practice in that unit? The two on the right, B91, B71, their end size is so low we kind of discount those. But CB4 definitely is worth looking into. And that's where you discover best practices and enhance organizational learning. I'm going to drill into opportunity days, which is our metric for length of stay. It's a risk-adjusted length of stay metric, and the way it works is basically if you have 0 opportunity days, that means you are exactly on your target benchmark length of stay. If you have positive opportunity days, you're beyond your length of stay. Negative opportunity days means your patients are being discharged in less than the target length of stay. So, for example, when I clicked on opportunity days, my admit sources popped up. If I'm a routine elective admission, I have negative 2,000 opportunity days. That's good. But if I came in through the emergency room, I had positive 2,600 opportunity days. We had that here at the clinic, and really the issue was patients coming into the ED, by the time they got assigned to a service and the service actually got a care plan going, we were losing a day or two of length of stay. So we had to enhance focus on patients coming and getting admitted through the ED, getting them onto a service and getting that service to have a care plan in place within a few hours. There are detail reports. So I told you about these icons. Everything on the right works the same way as the previous side. I'm going to drill into a detail report to show you how these work. So I'll drill into a detail report. And there's a little bit more data on this detail report. The first one is this discharge day of week. So the question is, do I have more opportunity days based upon discharge day of week? And it turns out, and this is pretty typical, that Monday and Tuesday have more opportunity days. And the reason for that, for us, was we were a 5-day-a-week hospital. And there were patients that could have been discharged on Saturday and Sunday that weren't getting discharged until Monday or Tuesday. So therefore, those lengths of stay of those patients on Monday and Tuesday were longer than they should have been. So that began to initiate issues around how do we become a 7-day-a-week hospital? How do we effectively discharge patients on Sunday and Saturday that can be discharged on the weekend? There's also detail reports that, and obviously I'm not going into detail on every dashboard. I'm trying to give you a sense for how these dashboards work. I went into my detail reports here, and this shows me the MSDRGs that have the most opportunity days, so the biggest opportunity to reduce length of stay, and the best performing MSDRGs on the right-hand side. Tell you, for example, that our best MSDRG compared to target is major joint replacement in this particular example. Now there's, again, various prefabricated reports across the top. We can drill into, for example, by service. And now you can see by service, how are the opportunity days. We sorted these into setting order by opportunity day. So let's drill into medicine, for example. And now in this scenario, you can see 13-week, 13-month, and year-to-year trended performance for medicine. So I might see an upward trend over the months for medicine, which concerns me. Up above, if I look at these last 13 weeks, what was it about the week of 329 and 45 that allowed me to have negative MSDRGs or negative opportunity days? You know, one question we always get answered is about attribution, and when we have physician-level detail, attributing length of stay issues to a service that rotates services every week or two is a challenge, and we've worked through various mechanisms to try to address attribution problems. So I'm going to move on to the last example that I'm going to give you, which is a nursing example. Really, the take-home message here was, create dashboards that allow you to really take action on the insights that are on that dashboard. This also, by the way, addresses the question of create a dashboard for the user. We have dashboards for nurse managers on a floor, for directors that are managing 3 or 4 nursing units, and then for the CNO. And this happens to be the CNO's view of the world. We have, within this nursing dashboard, there's productivity metrics, patient experience metrics, and quality metrics based upon NDNQI metrics. And for the CNO, the question is, our CNO, for example, has 11 directors reporting to her. So rather than make her go through each individual area to see what their performance was, we created this view. And this view has metrics on the upper left-hand side. So, for example, I've got it highlighted on total labor cost per patient day. I say I have 7 green lights and 4 red lights, and since I've highlighted that row, my 11 services show up on the left-hand side, on the right-hand side, and I can see in the far right which ones were red light, which ones are green light. And as a CNO, you can click into these. So let's click into respiratory, for example, because that has $43 negative variance, and I can see in my trend line below that actually respiratory was on target fine up until this last period. So either that was aberrant and it's going to be okay next time, or I want to watch that to see if that's a trend. If we go up to digestive disease, for example, I can see that they're $12 over, but they actually have had kind of improved performance over the past several months. They're getting darn close to their target. So that's making me feel okay. Let's drill into medicine. Medicine actually has a favorable variance, and as a CNO, being short of the target actually could be a concern because it might indicate that I have too few nurses on that floor, and now I have a quality issue. We can change the view for the CNO. So that's the CNO overviewing the organization. Let's say they wanted to drill into medicine. So they can shift the view here, entity by stat. I'm going to open up medicine. And now here are the individual metrics for the Medicine Institute. So when she's meeting with the person in charge of medicine, they can pull this detail up for all of the medicine nursing units. But let's say I wanted to see nursing unit level of detail within medicine. I'm going to go to a dashboard now that was built for the nursing director for medicine, and that director has multiple nursing units working for her she's in charge of. I'll click into G90 as a particular nursing unit. So now I've gone from in the entire organization into medicine down to one particular nursing unit within about 3 mouse clicks. And I can see my performance by metric for this particular nursing unit. And we see a lot of red lights on indirect, FTEs, premium labor. But you also notice on the same graph we've included average daily census. And I can see that my budget for census was 18.8. My actual census was 32.5. This was a true case here at the clinic. No wonder they had overtime and premium labor because they were trying to address this issue they had with a much, much higher census than budget. We did a lot of work with premium labor. And I'm going to go to the next dashboard to show you how we dealt with this. So this is G50 is a particular nursing unit. And I can see by payroll period on the left-hand side various categories of labor expense that we wanted to track. Overtime in the pay period 920 had actual $7,500 of overtime, budget of $1,000. So I wanted to drill into that variance. So I'll actually drill on the screen, and I can identify that for the pay period of 920, the $7,500 of overtime, 7,000 of it was RNs. So I'm going to click on overtime, click on RNs, and the actual names of the RNs popped up on the screen. So this level of transparency and the ability to drill within 3 or 4 mouse clicks to a very granular level of detail drove dramatic improvement in our organization. So this is the trend line. So for example, for nursing agency expense, we were spending about $500,000 a month on agency. Where this big drop is in the middle of the screen is where we implemented the dashboards. So just by focusing on it and having a dashboard that brought that level of specificity up, we cut about $200,000 to $300,000 a month in agency expense, and then over a period of about 1.5 years, we drove that down to less than $50,000 by identifying what were the root causes that were driving that agency expense. So lessons learned, we talked about were dashboards need to align with the mission. You want a system that provides transparency and accountability, orienting the dashboard to the specific users. Variation drives performance improvement, and provide a tool that allows for and facilitates action on the insights. The last one I added on here was really start with, there's grandiose ideas out there being discussed, saying build a gigantic data warehouse over a period of 2 to 3 years for $9 to $10 million, and then start building dashboard applications. We fundamentally disagree with that. We would say pick 1 or 2 strategic priorities of the CEO and build a dashboard around those 1 or 2 strategic priorities, and then grow organically. And if that first 1 or 2 dashboard is the right strategic priority and you demonstrate performance improvement, the acceleration of the dashboards will be much faster process. So with that, I think we're ready to open up the lines for questions.
My name's Dave Kaplan. I'm at New York Presbyterian. My question has to do with users and usage of the system, strategies surrounding accountability for usage, and also the access to patient information. I saw that noting the drill downs to the individual patient levels, whether there's policies surrounding that.
Dave, great questions. Let me start with the end. So there's no patient-specific, the patient identifiers on the dashboard. We're careful on the system, and we're careful at the patient level of detail who is allowed to get access to that detail of information. In terms of usage and establishing the accountability, I'm really glad you said that because I need to emphasize this if I forgot to say it. We really did not take off. Remember, we did not really take off until 1998 when the CEO really started paying attention to this. The very first dashboard we built had to do with patient access. It was a major issue of the CEO, and we built a very, very intuitive dashboard that helped him understand how difficult it was for patients to get into every department. And I remember it was almost a sea change moment when the first chairman came in and the CEO said, "Why is your red line so far away from your blue line?" And the guy didn't even know what his blue line was or what it meant. No chairman ever came into that meeting ever again, not knowing what his dashboard meant. So that's why you need to pick a dashboard that's strategically significant to the CEO, because the tool is built top down primarily as a tool that's going to drive strategic objectives for the organization, and it's built custom for the CEO and the C-suite.
My name is Shadab Kamal. I'm from the UCLA Health Sciences. The question I have is that what was the strategic drivers which basically provide the governance for selecting which dashboard needs to be going first? I mean, was this the patient experience? Was it quality, or was it throughput? I mean, or do you suggest that every organization will have its own strategic driver, which basically will drive the development of the dashboard?
I think great question, and I think that every organization would have its own set of priorities. I would start with what keeps the CEO awake at night, and then I would build a dashboard that very intuitively addresses what keeps the CEO awake at night. You build that first dashboard, and it addresses that problem, and you get performance improvement, you'll have no trouble having the initiatives take off from that point forward. I would like to say that the first dashboard we built was difficult. It was a patient access dashboard, and it addressed in a very transparent way the way the schedules were set up. And it was very obvious that we were having some issues with schedules being as open as they should be. And I would say in my 18 years here, 15 of them, we were doing all of the productivity initiatives that you would do in a hospital to improve productivity. The genius behind the CEO at that time and that particular dashboard was, in his heart, this was not about productivity, it was about patient first. So what I would say is, the culture of patient first kind of raised the level of what the organization was willing to do and how much the organization was willing to honestly evaluate its performance. And I think we got more done in 1 year with a patient-first mentality than we did with everything in the prior 15 years almost combined.
The supplementary question to that is, what was your biggest barrier in terms of adaptation of the dashboards?
Once the CEO was engaged, there was no barrier. I mean, the only barrier was technologically getting as many dashboards out as fast as we wanted to get them out. Even today, having done this for 5 years, we have 80 dashboards on the wish list. You can only build them so fast.
Would you explain a little more about how you organize the underlying data underneath your dashboards?
There's a couple ways to do it. One way to do it is you build an elegant data warehouse that, oh, by the way, I should, disclaimer here. I work for the number 2 guy in the organization, basically executive on the operational side of the house, not an IT person. So I can go about an inch deep on the technical side of any questions you might have. But I'd be happy to arrange conversations otherwise for anyone who needs a little more detail. I would say at a 30,000-foot level, there's 2 ways of going forward. One is to build an elegant data warehouse that brings in financial, quality, patient experience, operational data, and then building dashboards on top of that. Our thought is by the time you spend 2 years building an elegant data warehouse, unless you're consistently maintaining it, it's going to be difficult to, what you built over 2 years might be outdated by the time you're done building it. It's possible that could happen. The other thing is, there's got to be some sense of I'm spending money, I'm doing work, and I have to be able to show something for it quickly. So we've evolved over time to, yes, we're interested in building a mega data warehouse that would support many initiatives, including research and education. But really our modus operandi at this point in time is there's something strategic to keep the CEO awake at night. I'm going to build a data mart, and I'm going to build a dashboard which is intuitive off that data mart so I can demonstrate within 3 months that I'm driving performance improvement.
Do you typically have a dashboard for each data mart, or what's that right relationship?
A dashboard for each data mart is probably more than you'd like it to be, but you can have it down to a data mart for a dashboard to get something up quick and fast. I don't have any right answer to that question. By creating a data mart for every dashboard, the way I just told you, it's fast, it's appealing to the executives because you're showing fast movement and quick results, speed to value. In the long run, you have to have probably a second team that's kind of picking up some of the pieces behind and building up a more structured, more disciplined data warehouse.
Can you talk a little bit about data quality and particularly around attribution of cases to physicians?
Data quality is an adventure. One thing I'd say to you is with data quality, we'll create a dashboard. Before we publish it to the executive team, we let everyone have it and look at it and see what the results are for about 3 months before we'll let the CEO even get his hands on it. And 2 reasons for that. A, it gives everyone a fair chance to react to the data and fix their problem before it becomes, a public issue. And B, there's a certain period of time when chairmen or executives look at the data and say, well, that data's not right. That doesn't reflect the reality. And frequently that's true, and there's a percentage of the time when they are right, and you have to actually go back into the source systems and clean up your systems. And that's actually a great exercise because now you have a cycle going on where you're cleaning up the data is getting better and better. You acknowledge that the people who are creating the dashboards that you're open to, that kind of criticism, and you're going to fix it. So you get the reputation as the people who know the most about the data, understand it, you fix it, you make it right, and therefore adoption of the data is extremely high. But it's fully expected that you're going to have iterations of working through the data to get it cleaner and cleaner. In terms of attribution, for us we found that attribution, it depends upon the dashboard. If it's time of discharge, that's pretty easily attributed to the person who discharged the patient. If it's length of stay, for example, if you're an interventionalist or a surgeon who's managing the case throughout the entire stay, you're probably okay. If it's a cognitive service, and you're the guy who took the service today on Monday and you discharged 3 patients who were here for 3 months, you inappropriately got dinged for those 3 patients. So there's other methods that we've used other interventions we've used, particularly in the cognitive services.
This is Skip Falusik from Health East in St. Paul, Minnesota. How did your analyst strategy change over time?
The initial approach was we had operations analysts that really understood the hospital, but they didn't understand how to program. They were programmers. So they essentially learned how to do, we actually hired a consultant to come in who helped us build our first dashboards, and they taught us how to program in SQL. So the structure is data coming from the transaction systems into SQL, and then dashboard tools sitting on top of the SQL database.
Let me rephrase that question because you're describing your systems analysts. How about your actual business and clinical analysts? How has that changed over time?
Initially we had business analysts who are the ones that help design the dashboards. Now there's a central department that does all that dashboard design, so the analysts are trained up in how to use the dashboard in a consistent and appropriate fashion.
Do you see any skill changes as you progress?
I may not be the best person to answer that question. I would like to ask someone else that question who might be more into the details than I am into it. But I think in general what you've done is you've leveraged the time of the analysts because you've given them a much more intuitive tool to identify major areas of variation. They still will use their detail skills to drill into the very, very fine granular detail.
This is Sajid from Texas Health Resources. The question I have is piggybacking on the previous questions. Do you have a competency center set up?
We have a governance model in place where the CFO, the COO, some IT executives come together and determine how we're going to leverage this technology and what dashboards are going to be built next. The focus of what dashboards will be built next are usually based upon the strategic objectives of the organization. And then there is a centralized group that has grown significantly over the years that pretty much has the role of all the programmers are co-located, dashboard designers are co-located, and business analysts are co-located as we're rolling these out.
Tom, what tool set are you using for these dashboards?
I mentioned the transaction systems feed into SQL, and then on top of SQL, we're using a combination of business objects or Cognos right now.
Okay, you said business objects or
Yep, both of them.
Oh, okay.
I had a question about how you develop the targets for each one of the dashboards. Did you use a resource for benchmarking, or were those internally identified?
We used a combination of things for establishing the targets. So if it was financial, it was usually the budget. If it was operational, we tried to find a benchmarking source, or we would look at internal best practice. In some cases, we might have let's say the benchmark told us that an HCAPS target at 90th percentile. So actually, our default, for example, for HCAPS was if you're above the 90th percentile, that's green. If you're below the 50th, that's red. If you're between the 50th and the 90th, that's yellow. But we had a few cases where we were so far away from any realistically good benchmark that we just said, if we want to get to 80th percentile, we're currently at the 40th. If you made the 80th percentile the target, it would just depress people because they would be so far away from that goal that they wouldn't pay attention to it. So in those cases, we would kind of artfully pick something which was achievable, stretch goals. So we'd say, okay, this year get from 40 to 50, then the next year 50 to 60, then 60 to 70, and kind of ease them up to the ultimate target in piecemeal steps.
This is Sajid from Texas Health Resources. Do you have data stewards who are helping out across the organization?
Every area across the organization has an analyst, or probably at least one analyst working for them. And there are training sessions for those analysts, and there are resources that those analysts can call to get more information if they need more information. Remember one thing here, the dashboards are very focused. So, for example, when we addressed patient access in the organization, there might be 50 drivers of patient access that you might want to track metrics on. What we tried to say is, and this is probably learned through mistakes that we made over 10 to 15 years, what we try to identify is, okay, there's a strategic objective to achieve, in this case, patient access. So our goal would be, what are the 3 to 4 metrics that really move that dial? And then we do focused reporting, accountability on those 3 or 4 metrics rather than trying to track, 50 metrics. So you're not talking about lots and lots and lots and lots of metrics. And let me add also that you have my email addresses on the screen, and I'm happy to take calls or emails as well.
Tom, this is Chuck Appleby with Scottsdale Institute. How does the data that you produce, how does that get translated into, say, practical reporting to CMS or quality in anticipation of the need to report?
Chuck, we may do regulatory reporting off of a data warehouse that we would build to drive these dashboards, but the primary purpose of the dashboards is to drive enterprise performance management and the dashboards. We may or may not always have all the information necessary for regulatory reporting with these tools.
If there are no further questions, we'll thank everybody for coming. And Tom, thanks a million for the talk today. It was great. We'd love to follow your progress. And those of you that are on the line and may have some follow-up thoughts, please don't hesitate to get a hold of Tom. Or if you don't have that handy, please just give us a call or an email at Scottsdale Institute, and we'll forward the question directly to Tom. So thanks, everybody, again for coming, and thanks a million, Tom, for the presentation today. We appreciate it.
Thank you.